Okay. So now these are the FOB cases book. Now coming back to task cases book. These are the task cases book. Same for task cases book. Main book is task clinical cases, 50 cases. Science of Pediatrics is a very good book. Okay, many questions like um, many questions directly come, like there are some ophthalmological cases, there are some um, dermatological cases, there are some pharmacological cases in task cases book, also cardiology, then respiratory, many cases. Okay, directly question comes from this book. This is a reference book, and these 50 cases, actually not only 50 case, you have to remember this is a system. Okay, this is a system. Each chapter consists of each system. Okay, that's why task cases book and FOB cases book are very, very important. You have to revise it like 3 times, 4 times. Okay, and you have to make some notes for that purpose, and those notes will be important when you are going to exam hall. These notes will be helpful. Then Science of Pediatrics book is also very important, and though it is a very vast book, Science of Pediatrics, but Science of Pediatrics, you can divide it in small chapters, and when you are reading like respiratory chapter, you just have a look. There are certain boxes in the Science of Pediatrics book, and those boxes you can see as a reminder. Okay, because those boxes are like pharmacology, some boxes are causes of respiratory distress, like this. Okay, so these boxes are very, very important. And then again, ethics question will come in TAS, palliative question will come in TAS. Pharmacology is an important chapter in TAS exam. This we have to remember. Pharmacology, there are basic pharmacology and clinical pharmacology. Some question will be like basic pharmacology, like drug metabolism, drug absorption, drug volume of distributions. These are basic pharmacology. And some pharmacology like clinical, like what is the drug treatment of epilepsy, what is the drug treatment of ADHD, like this. Now again, basic subject like pathology, microbiology. Microbiology is very important. Gram positive, gram negative, cocci, bacilli, virology, fungi. Okay, these are very important. And sample papers, as I already said, sample papers are published by Rcpch, so those are very important. And recalls also here important, and statistics. It is most statistics is a very a bit tough, and so statistics, I think uh, you should not omit it, because in Mrcpch AKP and also Mrcpch clinical exam, you have to read statistics. And the Science of Pediatrics book, it has statistical chapters. Okay, I think if you go through that Science of Pediatrics book, it will be very easy and very reliable source for you, because this Science of Pediatrics book actually published by Rcpch, so you can blindly trust on that book. Okay, now have you any question until now about the exam, because we are going to start our neurology scenario now? Anyone having any question, you can ask me. Open your mic, you can ask about anything, about exam patterns or anything, you can ask. Okay, okay, if no question, we are going to directly to the question pattern now. What type of question usually comes in our Mrcpch exam? Okay, you have to have a very good idea about this question pattern. Okay. Epilepsy is an important chapter in Mrcpch. Epilepsy, without epilepsy, I always say there are few chapters that are very vital, like epilepsy, like bronchial asthma, like diabetes mellitus, type 1 diabetes mellitus. So epilepsy is one of the important chapter that you cannot deny, you cannot omit. And you have to read details from the Red Book Pediatric Guideline, also the NICE guideline, okay? And you have to see the videos in YouTube. like what is Ronaldic seizure, what is myoclonic seizure, what is absence seizure, okay, what is night terror, what is nightmare, okay, like this kinds. There are different kinds of seizure, and those differentiating these seizures is very very important. As a pediatrician, as a examinee, you have to know that which type of seizure a baby is having. So first question came in 2020 October, last exam, okay. That was a child who has abnormal movement in one side of the face, and there was abnormal eye movement, drooling, swallowing at night during sleep, and after the sleep, after the seizure, he felt tired. That is called post-ictal drowsiness. So what type of seizure it is? Now we have to remember that epilepsy can occur in early morning, can occur during sleep, can occur during hyperventilation, photic stimulation, during class, okay, when the child is mentally exhausted. So you can provoke seizure, okay. So there are special types of seizure that occur at night. This is Ronaldic epilepsy. You will hear some gargling sound the child is making, and some, abnormal movements. It can be localized, it can be generalized. Localized, like it can involve face, one half of the face. The child may have drooling, the child may, bad dreams. Parents will understand that this is a bad dream, okay. And in the morning, parents may go to GP or any doctor, and then doctors may do an EEG, but there'll be nothing. Usually post-ictal EEG is normal. I mean, when the child is not having seizure, it is normal. So this kind of epilepsy is called Ronaldic epilepsy. Usually it is benign. This is name is PECTS, benign epilepsy of the centrotemporal spike. It is a benign kind of seizure. Usually it resolves after like adolescent age, okay. It starts on the early, like 5 6 years, and then usually it resolves within adolescent. Usually no drug treatment is required, okay, only reassurance. But sometimes this Ronaldi can become generalized, okay. In that cases you may need some drug treatment. And if you do EEG during sleep, during the attack, we will find there is centrotemporal region. I mean, have you seen the ECG leads, right? Most of you have seen those ECG leads. One lead indicate one area of the brain, and the EEG is recorded just like ECG, the events, the post-ictal events, okay. Just 1 minute. Okay, sorry for that. So the post-ictal events you can record if you do this EEG at the time of the seizure, okay. You will find centrotemporal area, you will find a specialized wave, spike and wave, okay. So this is benign Ronaldic epilepsy. Now the second question, the scenario about toddler got pale, and there was loss of consciousness, and for a second after hit his head by table with muscle twitching. That means the child was very pale, and there was loss of consciousness, and there was a history of minor bump or minor injury, and the child got stiff. Suddenly he became pale, loss of consciousness, and there was jerking movement. This is called reflex anoxic seizure. Reflex anoxic seizure is a special type of uh, seizure. That is, sometimes it is confused with the breath holding attack. But breath holding attack, actually the child is very tantrum, like she or he is crying for something, got tantrum, and then the child is having, holding the breath, and then the child is having seizure. This is breath holding attack, okay. So breath holding attack and reflex and seizure, what is the difference between these two? Breath holding attack can be pale and can be Breath holding attack can be pale, can be blue, cyanotic. But reflex anoxic seizure, the child usually the child is pale. Okay, and there is a history of minor injury, minor bump. But reflex anoxic seizure is a different form of breath holding attack. In breath holding attack, child has temper tantrum. He is very much angry or anxious, or he doesn't like something like this. Okay, and in both the cases, reassurance. We will give reassurance. Another is that sometimes there is an association between breath holding attack with the iron deficiency anemia. So we will correct iron deficiency anemia first. Then we will see that the seizure, actually this kind of special seizures, is reduced. Okay. So the next scenario was a child having fever 39, that is around 101, and there was abnormal body movement, and that stopped when you touch him. So this is actually rigor, chills and rigor. Okay, so this is not seizure. When you touch the child and it stopped, okay, this is not seizure. There is another kind of movement that is occur in neonate, that is called jitteriness. Okay, jitteriness and
Jitteriness.
rigor. Yeah, jitteriness and rigor, what is the difference? Jitteriness usually occurs in neonate. When this occurs with temperature, we call it rigor, chills and rigor. And rigor, there is a history of temperature, but jitteriness, there is no history of temperature, right? And in jitteriness, the child neonate may have hypocalcemia, hypoglycemia, but in that time, if you touch the child, it will not stop, right? So you have to know the difference between rigor and jitteriness and convulsion. Okay. Now the next scenario that usually comes in exam, that is a child who has first attack of convulsion, less than 5 minutes. Okay. And when he was very small, he had febrile convulsion. Mother is asking you for anticonvulsant therapy. Will you give him? No. For starting of anticonvulsant therapy, we have to know there are certain criteria, like recurrence of the symptom, like at least more than one attack, I mean two attack, at least two attack, unprovoked attack. Unprovoked means there should be no fever, there should be no injury, there should be no family history. Unprovoked, there should be no hypocalcemia, hypoglycemia, like this. These are called unprovoked. Okay, so more than one or two or more unprovoked seizure that is lasting for more than 5 minutes, and more than 5 minutes is also called generalized. What is that called? This is called status. Okay, we have to remember that more than 5 minutes is a new definition. If the child does not regain consciousness within 5 minutes of seizure, this is called status. So if any child has status, okay, and the child has a family history, this is called provoked. In those cases, we start usually anticonvulsive therapy. And we have to remember, as a pediatrician, we must refer to the neurologist. Okay, because we cannot start treatment without any prior knowledge about the epilepsy. Okay, we have to take detailed history, we have to examine the child, we have to do certain investigations. If the EEG pattern is suggestive of absence epilepsy or myoclonic epilepsy, we can do EEG, because there are certain types of change we can see, right? Now the next scenario, so in this scenario, what is the further action? Further action is you have to tell the mom, reassure the mom that this is only one attack of unprovoked seizure. If there is another event of same kind of attack, we will start anti-epileptic drug, provided by, we will refer your child to neurologist. Okay, so this is our agenda. This kind of question, like epileptic events, different kinds of epilepsy, these kinds of event usually very common in exam. Now, until now, if you have any question. There was one question that pallid spell is usually associated with that is a part of breath holding attack. And reflex anoxic is also pallid. So how to differentiate? There is actually no difference criteria. Okay, you have to know that breath holding attack, there is a repeated history of same kind of pallid attack. Okay, and reflex anoxic seizures are usually not repeated. Usually it occurs with an injury, sudden. Suppose a child has sudden frightened, or sudden he saw some blood, or he got some injury. That is reflex anoxic seizure. The child got frightened. But breath holding, this is a recurrence. You will see when the child having temper tantrum, that time the child having seizure. Okay. And family history is very important in breath holding attack. Family history is not, maybe not present in anoxic seizure, but family history is very important in breath holding attack. So there are actually, these criteria are very faint. These are not so much well recognized criteria, but there is certain borderline for reflex anoxic and breath holding attack. Doctor is asking, please repeat difference between rigor and jitteriness. Okay, I will share this in my YouTube also, and also Facebook. You can see our lecture later on. And documented 2 minute is hospitalized. Should we start IV? No, no. Documented before 5 minutes, we usually do not start IV, because how you know within 2 minutes you cannot go to hospital, right? Number one, within 2 minutes you cannot go to hospital. You have to stay at home. So what we teach the mother, that first of all, when the child is having seizure, do not give anything to mouth. Do not hold the child, just left lateral position. Okay, left lateral position, and keep the child calm. If the seizure is 5 minutes, then give drug. What type of drug? That is midazolam, buccal spray, right? We teach the mother like this. Parental diazepam now we don't use, and oral drug that now we don't use. We only use midazolam. If the child is hospitally admitted, then it is a protocol. There is a protocol for seizure. Okay. If the child is already known case of seizure, then definitely again he's developed seizure. Definitely we will go IV. Then why we will go buccal, right? So there is certain indication. Buccal usually we give when the child is at home. No one to give IV, right? So in this scenario, question number 2, we will wait for further symptom. Then we will teach the mom that please come back, return to us if there is another event. Okay. Now, another scenario was unilateral facial palsy has wrinkling on the forehead. What does that mean? Unilateral facial weakness, wrinkling present. Wrinkling present
Seven
means,
nerve palsy.
yes, which type of seven nerve palsy? Upper and lower, which type of palsy it is? Wrinkling present.
Upper.
Very
Upper
good.
UM pulse.
Yes, it is upper. So when there is a upper nerve facial palsy, okay, and what is the next investigation you will do? Definitely you will do
MRI.
MRI, because there is a raised intracranial pressure. Definitely, very good. But if it is a lower motor neuron palsy, we can wait, because mostly it is Bell's palsy. We can wait. It is viral. It will auto resolve, right? Dr. Samsung Galaxy. If you have any question, you can ask. Any question, anyone, until now? Okay, I know there are a lot of questions. Some people are hesitating not to ask. Please do not hesitate. This is your show, and the show must go on. Okay, this is your show today. Okay, so we have to know that if any child having sudden onset of upper motor nerve palsy, anything, third nerve, seventh nerve, sixth nerve, anything, sudden onset, indicating a raised ICP. It can be ICSOL, that is intracranial space occupying lesion. It can be tumor. It can be abscess. It can be idiopathic intracranial hypertension, IIH. It can be any bleeding inside. So anything, when there is a sudden nerve paralysis, upper motor neuron, you have to do MRI to rule out the pathology. Okay, this is an surgical emergency. Even in a child having sudden onset of squint, a child, suppose 5-year-old, he does not have any squint before. Suddenly he started squint. So this is a indication of raised ICP. Okay. Now the next paid topic. Next paid topic is that is called infantile spasm. 8 months baby who has abnormal chaotic appearance of the EEG. This is called what? What is this called? Abnormal chaotic pattern in West syndrome. What is
Hips,
that called?
hips rhythmia.
Yes, it is.
Hypsarrhythmias.
Yes, it is called hips arrhythmia or hips arrhythmia. This name is very common, right? And do you know that sometimes West syndrome may be idiopathic? Sometimes it is associated with a syndrome. What is that syndrome? Who can tell us? What is the syndrome that West syndrome is associated most commonly?
Tuberous sclerosis.
Yes,
Tuberous
tuberous
sclerosis,
sclerosis.
no?
Yes, yes, very good. So, if tuberous sclerosis is complex with, I mean, combined with West syndrome, that the drug of choice is vigabatrin. Okay,
Gabby.
but
Vigabatrin.
sometimes, sometimes tuberous sclerosis is not associated. Yes, so sometimes there is no tuberous sclerosis, only hypsarrhythmia, only infantile spasm. What is the treatment only then? If there is no tuberous
Steroid.
steroid,
AC,
yes,
Steroid.
ACTH and steroids.
ACTH and steroids, yes, but there was no option of steroid. So what you choose? Just 1 minute.
Vigabatrin.
Okay, sorry for this interruption. Actually, I got a call from hospital. Okay, so now next question. Okay, what is this? Can you just erase this screen from who wrote this? Can you just erase someone? Okay, so this question I was asking the infantile spasm, only infantile spasm. That first treatment is ACTH and steroid, and sometimes also we can use other varieties of drug. So we have to remember that West syndrome may be associated with tuberous sclerosis, may not be associated with tuberous sclerosis. Okay, so this is very important. Now next question. Okay, any question until now, anybody? Any question until now? Anyone? Okay, so we will proceed now. Next question is, Patient came with vomiting and examination showed some petechial rash. He received metoclopramide. Then he developed stiffness of the neck or rolling of the upward rolling. This is called what? This is called upward rolling and stiffness of the neck or stiffness of the body. What is the name of this syndrome? It is called extrapyramidal syndrome or oculogyric crisis, and it occurs after
Dystonia.
yes, dystonia. Yeah, very good. It is dystonia with rolling of the eye. This PTG, actually, this is not meningococcal meningitis. You have to remember, in meningococcal meningitis, there is no rolling of the eye like this. Okay, rolling of the eye with stiffness, dystonia. This is called extrapyramidal syndrome. And this PTG may be due to viral rash. Any viral rash can cause PTG, right? Like, we know the Epstein-Barr virus, cytomegalovirus, any virus can cause PTG. So this PTG is not meningococcal meningitis. Okay, meningococcal meningitis, the child will be very sick. He will come with shock. So this is not like meningococcal meningitis. And there was no option of meningococcal meningitis. There was option like myoclonic seizure, Ronaldic seizure, oculogyric crisis like this. So it was oculogyric crisis. Next is question number 2. Okay. Boy, 7 years, came with absence seizure. And in the EEG, there was some 3 spike per second. That means, like, I call it VT like this. I call it VT, 3 spike per second. This is 1 second. Okay. This is 1 second. And there is 3 spike, look like VT, ventricular tachycardia. Okay, I call it VT. So this is 3 spike per second. It is a characteristic criteria for absence seizure. And what is the treatment of absence seizure?
Absences.
What is the treatment of this boy, 7 year?
Ethosuximide.
Ethosuximide, lamotrigine,
Yes,
sodium
but
valproate.
sodium valproate is the best drug for absence seizure. But what if it is a girl? What we will give if it is a girl?
Lamotrigine.
Yeah,
Lamotrigine.
Ethosuximide.
yeah, yeah. Ethosuximide and sodium valproate, better is sodium valproate. Sodium valproate works better. But for girls, we cannot give. Why? Who can tell me why for girls we cannot give?
Tetragenic.
Neural tube defect.
Yes, because she may become pregnant when she is adolescent or adult, and she will continue valproate. So she can have neural tube defect child. What is next? What is next? There is another reason, cosmetic purpose. Okay, sometimes with sodium valproate there is alopecia. Okay, there is gum hypertrophy. There is, some facial deformity, some abnormal features. Girls usually do not like this. Okay, so the mild facial change, it will not bother any boy, but for a girl, alopecia something, this is very, they will feel, psychologically upset. So sodium valproate actually we don't give in girls. In UK, usually they give ethosuximide or lamotrigine. Now, there is 2 drug that is very good for girls or pregnancy. That is love.
Lamotrigine
Yes,
and
lamotrigine,
levetiracetam.
levetiracetam. Yes, this is, I call it love for the mother. Lamotrigine and levetiracetam. Okay. Now next. So in this case, 7-year-old, we will give sodium valproate. Okay. Next question was 8-year-old. A 8-year-old girl came with morning headache and poor sleep. Third question. Okay, we are going third question. 8-year-old came with morning headache and poor sleep and new onset squint. What is the diagnosis? See, I told already that new onset nerve palsy, squint, very, very important for
Raised intracranial tension.
raised intracranial pressure. Yes. So what is the diagnosis? Space occupying lesion. Okay, because morning headache, vomiting, less sleep with early morning vomiting or sleep or with new onset of squint. This is space occupying lesion. Yes, done. Next question. Okay. So the next question is, child who admitted in the ward with bronchiolitis and he has fever and convulsion for 2 minutes. Now this question was asked by one doctor, that if the convulsion is for 2 minutes at home or at hospital, what should we do? Hospitally admitted child, their protocol is different. But when the child is at home, we teach the parents that do not give midazolam spray until 5 minutes past. We teach the parents. Or the child is not stopping seizure, or if the child is having some red flags. What are the red flags? Red flags are like cyanosis, breathlessness, or pale, or become like respiratory difficulty, like this. These are the red flags. We teach the parents that these are the red flags. Then only start the treatment. Okay. So we have to remember that when we will give anti-epileptic drug, this is very important. So in this case, we will observe, because see, there is no risk factor. Oxygen was 94, saturation is good. RBS, that is random blood sugar, was 6 millimole per liter. That is very good. Okay, this is very, you have to remember these things. Observe. Any question until now, guys? Any question? You can open your mic and ask. Okay, now next. This is extended medical question.
What is the drug of choice in
Yes. What is the drug of choice in?
hello
Yes.
absence seizures?
Absence seizure, for boys, we usually use sodium valproate. Then we can use ethosuximide, lamotrigine also. But for girls, we will avoid sodium valproate. We will use lamotrigine or ethosuximide. Okay.
Okay. Okay. Thank you.
Next. This is an extended matching question. Okay. And you see there are multiple options. There will be 8 to 10 answers. You see this. This is multiple options. This is the answers. Okay. These are the answers. And these three are the question. 1, 2, 3. These are the question. Okay. So this is called extended matching question. Now, in this extended matching, there is 3 scenario. First scenario is a child who is very frightened, pale. There is repetitive swallowing for 15 to 30 seconds, after which he is tired. What type of seizure it is? So you have to remember that benign partial and complex partial. What is the difference between benign, that is called simple partial, not benign, simple partial and complex partial? In simple partial, the child having,
Aura.
yes, aura is one difference. Another difference is post-ictal drowsiness, post-ictal tiredness. In
Dozens.
aura, yes, in post-ictal tiredness, it is present in complex partial seizure. But simple partial seizure, usually there is no aura, usually there is no post-ictal drowsiness. Clear? In both the cases, the child may be very pale or repetitive swallow. This repetitive swallowing movement is actually, it is seizure. We have to remember, okay? So this is complex partial, when the child is tired. You see, the child is tired. Okay, there is a option, the child is tired. Okay. So this is complex partial seizure. This is not benign partial or simple partial. Next question. A girl.
Excuse me, ma'am. Sorry to disturb.
Yeah,
Ma'am, I
yeah.
want to ask again that in simple partial, there will be no aura and no post-ictal drowsiness, right?
Yes,
It will
yes,
be opposed in the complex partial. Right?
yes, yes,
Okay,
yes.
ma'am. Thank you.
And and partial, simple partial usually short time. Usually it does not convert into generalized, but
Okay.
complex partial can go into generalized, because
Okay.
this is high risk. Okay, this is high risk seizure.
Okay.
And second question is a girl who has, in the assembly, PT, morning physical examination class, lost her consciousness, pale, twitching after she regained consciousness. She is confused. But they did not say there is a drowsiness. They said she is confused. So this is syncope. We have to remember, this is not seizure, because there is a history of prolonged standing on the heat. The child faint. And we have to remember that in seizure and syncope, sometimes it is confused. A child having seizure disorder, he can get into syncope. So this is not so easy. But here the scenario is child is standing a long time in the heat or in the playground. He became pale, then there is a seizure. Normally, when a child having convulsion, he doesn't become pale first, normally, unless there is an autonomic component. Some seizure has autonomic component, right? Unless there is an autonomic component, seizure does not associated with pallor usually. Okay, so this is actually syncopal attack, prolonged standing. There's a vasovagal attack. Okay, any question
Hello,
until?
madam.
Yes.
What about twitches in this question, madam?
Yes,
Twitching movement.
this twitching movement can occur. Even there is urination, even there is a micturition, urination, even possible for syncope. Okay, so this is prolonged standing, pale. These two goes in favor of syncopal attack. Okay, twitching can
But why
present.
she's confused?
Yes, I told confused and drowsiness. These two are not same. Confused because there is a cerebral cutoff of the blood flow. For a brief period, the child can be confused because there is a cutoff, okay, where she is for a brief period. This will not stay long. The child will not become drowsy. Drowsy and confused are not same time, okay? Drowsy means he is gaining consciousness a little bit slowly. This is drowsy. But here the child will gain consciousness, but he will be confused for a certain moment. Another point, another point is that during seizure, the child cannot recall the event. But during syncope, the child can recall the event that I was standing a long time and I felt lightheadedness and I felt very hot, flushed. Then I fell down. The child can say, okay, he may confuse after some time due to cerebral hypoperfusion, but it will soon resolve. Okay, so this is actually syncopal attack. Okay, and this twitching movement, if they say this is jerking movement, whole body, then we should become confused because usually in syncope there is no jerking movement. Okay, so this is syncope. We have to be very clear about syncope and then seizure. Now the next question is also very important. A child who is at school noticed by the teacher that he goes still means and no movement with 1 to 3 minutes, within 1 to 3 minutes. What is that? Why this is daydreaming? Why not absence seizure? There will be more option. Okay, there will be more line, like when you recall the child suddenly respond. This is daydreaming. In daydreaming, a child is responding, but in seizure, absence seizure, the child will not respond. In daydreaming, if you call the child will tell the name and the child will immediately recall the event. But in absence seizure, the child is totally blank. Those few seconds, 30 seconds or 1 minute, totally gone from his life. This is absence seizure. And daydreaming usually occur when there is, the child is busy at that time. But absence seizure can occur at any time. Okay. So these are the different types of seizures. And we have to remember daydreaming is not a seizure. Syncope is not a seizure. They are funny turn. Okay. They are not seizure. What is funny turn? We will tell later on. But complex partial is a seizure. Okay. Any question until now?
Ma'am, how can we differentiate twitching from jerking?
Twitching actually, this is syncopal attack. There is cerebral hypoperfusion. So that can create some problem like, some muscle twitching, some area. But in generalized tonic-clonic seizure, usually it is not started with twitching. And in absence seizure, usually there is no twitching. Okay, there is nothing. Okay, and in syncope, this twitching is due to cerebral hypoperfusion because there is a pulling of blood into the peripheral part of the body and cerebral blood supply is cut off for a few brief moment. This is the syncope, right? So they will give you more scenario like the child is talking with you again, For few minutes he was confused, but then he started talking with you. There is no drowsiness, no weakness. They will give you more points. The real exam question will not be like this, only three line, 1 line, 2 line. It will be like a 4-5 line question. Okay, so they will give you some other criteria. I think you should not bother about this understanding. You will bother, but you have to know, basically you have to know the problem. Where is the problem? Okay. Next question is, what is the most important indication to do CT scan? This is a very paid question. Indication of CT scan during headache. Okay. Okay. So there are certain indication of CT scan, like any child who is new onset of squint, indication of CT scan. Any child who is having sudden severe attack of pain, headache, this is indication of CT scan. Any child who has morning vomiting, morning headache, early morning headache, that means there is a raised ICP. This is an indication of CT scan. Okay, so waking up with vomiting, this is an indication of raised ICP, and we have to do CT scan. Okay. Any question until now? We finished our pre-calls. Now we will describe certain types of seizure. Until now, any question, anyone? You can ask.
Excuse me, ma'am.
Yes.
Regarding the investigation for CT scan and MRI, there's confusion most of the time. Like sometimes we are thinking CT scan will be the best option, and sometimes MRI. Like you told before, in a space occupying lesion, MRI will be the better option. But CT scan is also, so how we will select this one? I mean, what will be our choice if the both option will be there?
Okay. Number one is MRI is very important in certain situation. Like MRI is very important when there is a posterior fossa tumor. Okay, MRI is important in base of the skull pathology. Okay, like circle of Willis problem. Okay.
Okay.
And another is CT scan is best for recent onset trauma, like head trauma. CT scan is best because the blood usually visualized in the CT scan. Okay. So CT scan and MRI, in case of headache, if it is chronic headache, we will prefer MRI or MRA, magnetic resonance imaging. Why? Because when we are suspecting that this is a kind of pathology in the cerebrum, I mean the matter cerebral hemisphere, or in the vessel, then we will do CT scan best. Then we will do MRI. Yeah, when we think there is a pathology in the cerebral matter. But if we think there is a bony pathology or there is a recent bleeding, then we will do CT scan.
CT scan, okay.
Soft tissue shadow is best in MRI.
MRI, okay.
And yes, and bony shadow or bleeding shadow better in CT scan. So you have to understand, like, MRI is best for tumor. MRA, magnetic resonance imaging or magnetic resonance angiography, this is best for pressure, blood pressure, like, idiopathic intracranial hypertension. Best is MRA. Okay, because we are thinking about pathology in the blood vessels. So you have to know where is the pathology, what is the pathology. If there is a trauma, MRI is not best, CT scan is the best. If there is an intracranial tumor, CT scan is not best, MRI is the best. Okay.
Okay, thank you.
Yeah. And Dr. Vivo 108 asking, Madam, kindly answer my question. What is the answer? What is the question? Sorry, I did not hear your question. Okay, can you ask me again? What is the question, Dr. Vivo? Okay, I will wait for your question now. Now let us see what is daydreaming. I just told you that there is an option for daydreaming. We will discuss. So what is daydreaming? Who can tell us what is the difference between daydreaming and absence seizure? We just told. Who can tell us?
Cannot recall the incidents before in case of absence seizure.
Yes, and in daydreaming,
And
response.
Yes.
In daydreaming, patient
Child
response.
can respond in daydream.
Yes. Yes, patient in responding in daydreaming immediately, and post-ictal event will be absent in daydreaming. But in absent seizure, the child may become very, sometimes weak, because who can tell me absent seizure is a generalized seizure or partial seizure? Is it a generalized?
Generalized,
Partial.
generalized seizure.
Generalized seizure.
Is a kind of generalized seizure. That's why. So the child become sometimes the child become drowsy. Okay, in case of absent seizure. So absent seizure is not good. We have to remember that even absent seizure is not good. Okay, daydreaming you can inhibit the child, but absent seizure is actually you cannot stop without treatment. Okay. Now, to determine is it daydreaming or seizure, check the vacant look of the child and get in front of the child face and ask, can you hear me? Can you hear me? Point to the ceiling and ask your child to look. Where are you pointing? Look at the ceiling. Look at the ceiling like this. Tell your child to remember a word like green duck. Did you see green duck today? See this photograph in the picture. This the child is daydreaming. Okay, green duck is a green duck. Why we are saying green duck? Because just to remember the word when the child having conversation with you, just say what I told you a few minutes back. Which color of the duck was? It is a green duck. Okay, he can remember. Okay, this is a daydreaming. Watch for lips smacking, picking at clothes, eye blinking, fluttering, humming, or other repetitive behaviors while staring. Because sometime in absence, the child may have these symptoms, lip smacking, picking, but in absence, the child usually does not have these problems. Okay, so this is called daydreaming. Okay, Alice in Wonderland. Alice is a child. Okay, Alice in Wonderland syndrome. Have you heard the name Alice in Wonderland? Alice is a child who is having repeated times of daydreaming. She thinks that she is having, she is living in a world that is Wonderland. Okay, this is called Alice in
Epstein-Barr
Wonderland.
virus infection,
Yes,
infectious
yes,
mononucleosis.
yes. And Alice in Wonderland, the child may have daydreaming several times. Okay, next. This is the very important slide. This slide indicate clinical appearance of generalized seizure and syncope. Okay, the slide is clear to you. Anyone can remind? Slide is clear.
Yes, ma'am.
Okay, so what is the difference between a seizure and a syncope? I already told the child cannot remember the recall during seizure, and seizure is usually more than 1 minute, but syncope usually less than 1 minute. Seizure, there is a precipitating event absent. It can occur during any time or even during sleep. But in syncope, there is some event like prolonged standing, stress, exercise, excitement. Okay, so there is some events. In seizure, the child sometimes has aura or same type of attack repeatedly, but there is no aura usually in syncope. But before the attack, the child may have lightheadedness, dizziness, and the child will feel hot flush and then sudden blackout. This is called syncope. Rarely a syncope may have urination, defecation, as I said, rarely. Now, motor activity like, clonic, myoclonic, tonic, clonic, or facial movement, not only twitching, there will be motor activity in the seizure. But usually after the syncope or during the syncope, the child is very flaccid. He is not rigid, he is flaccid. Urination, defecation, hyperventilation, these are common. But hypersalivation, sorry, but in syncope, urination, defecation, they are very, very rare. The child become unconscious, but the child in syncope, he is not unconscious. He is a little bit confused, but not unconscious. Okay. Episode can last long time, seizure, but syncope episode is very short time. Now, signs following an event like postictal drowsiness, the very slow recovery, this is seizure. But usually in syncope, it is rapid recovery, okay? Any question until now? Any question until now? So we are doing our different types of seizure. Okay, we are resolving one by one. We know now where is our weakness so that we can cover our weakness. Now, what is absence seizure? Who can tell us? Maximum how many time a absence seizure can occur? Can anyone tell us maximum how many time an absence seizure can occur to any child? Unlimited time. Okay, unlimited time an absence seizure can occur. This we have to remember. And now absence seizure, usually previously it was called Titmal seizure, now it is called absence seizure. And any child who can have multiple time, unlimited times of seizure, even in the classroom, even during toileting, even during bathing, even during, and that's why any seizure child is very dangerous if you lock the door, or if you go swimming, or if you're cycling or driving, very dangerous, because anytime they can have starting seizure. So usually any children, we do not allow swimming alone, we do not allow living in a room with closed door alone, we do not allow. So, and another important point is that this kind of seizure is very dangerous. Even multiple time absence seizure is harmful for the brain, so you have to stop the seizure. Okay. Sometimes these children are usually complaints by school that your child doesn't give concentration on class, he's looking at somewhere. But when we take history, when we do full examination, the child does not respond during the event. This is called absence seizure. And it is actually very short, 5 to 15 minute, 5 to 15 second. Okay. Sometimes there is a eye blinking, lip smacking, this kind of movement occurs. And there are special stimulation like provoking stimulation, like photic stimulation. Okay, this can actually provoke the seizure. And absence is always a generalized seizure. So any question regarding absence seizure? Now the next important topic, next important point is CT scan indication in head injury. Okay, this is very, very important. Head injury, we do not usually at the when there is a head injury, at the same time, in all the cases, every cases, we do not do CT scan. Only if the child has a high risk factor. What is high risk factor? Suppose any child is admitted with suspected non-accidental injury, like we call it NI, non-accidental injury. Like suppose the child had posterior fracture or fracture of the multiple side of the body, then, or there is a swelling in the eye, around the eye, that means there is a chance of bleeding inside the brain, so we will do CT scan within 1 hour. Suppose the child has post-traumatic seizure, after trauma the child developed seizure, then we will do CT scan. Suppose any children who has GCS score 14 who is less than 1 year, and GCS score 13 who is more than 1 year. That means 14 or below who is less than 1 year, 13 or below who is more than 1 year. Okay, so GCS 14, GCS 13, they are even very dangerous. We have to remember, okay? But injury before 2 years, even then the child's GCS is less than for 15. So we have to do CT scan urgently. But we have to remember any comatose child, any child who has coma or who has, unmovable condition, you cannot do CT scan. Okay, because this is contraindicated in a debilitating, like the severely ill child, we cannot do CT scan. Suspected open or depressed skull fracture, or if the fontanelle is tense, after injury, then we have to do CT scan within 1 hour. If there is any panda eye or hemotympanum or CSF leakage or bruising on the mastoid, that is called battle sign, we have to do, because these are the signs of the base of the skull injury. Then if there is any focal neurological sign, suppose facial nerve palsy or third nerve palsy or sixth nerve palsy or arm or leg palsy, you have to do CT scan urgently. Any child who is less than 1 year, there is a bruise or swelling which is more than 5 centimeters on head. This question came in exam, more than 5 centimeters. This question came like 4 centimeters. Okay, 4 centimeter swelling, we will not do. If it is more than 5, we will do. Okay. So if these are the single factor, these are the single factor when we will do CT scan. But second paragraph, this is more than one factor. I mean 2 factor needed. Suppose any child who has injury and he is lost of consciousness for more than 5 minutes. Witnessed means someone witnessed the loss of consciousness. This is indication. Abnormally drowsy, more than 2 vomiting. 2 vomiting is not indication. More than 2, that means 3 vomiting. Dangerous mechanism of injury like blunt trauma, a dangerous blunt trauma. Then high speed road traffic accident. Suppose cyclist with vehicle. Then fall from height more than 3 meters. So remember, 3 vomiting, 3 meter. And more than 5 minutes, that means 6 minutes of loss of consciousness. These parameters are important because these parameters you will get question in exam. Okay. High speed injury, projectile injury like bullet, or amnesia more than 5 minutes. So remember, more than 5 minute amnesia, more than loss of consciousness 5 minutes. More than 3 meter height, more than 2 vomiting, that means 3 vomiting, at least 3 discrete vomiting. Now, if there is no risk factor and 1 moderate risk factor, we will observe. Okay, we will observe 4 hours. If there is nothing, we will discharge. If the child deteriorating, we will do CT scan. Okay. If the child is on warfarin therapy or some other therapy, then you need CT scan within 8 hours, because in a child who has warfarin therapy, blood is very thin. They have tendency, okay, to bleed. So we will do within 8 hours. Any question until now, guys? Now, next chapter that is also very important. That is, when a child having headache, when we will do CT scan or MRI. One doctor asked this question and we described when we will do CT scan, when we will do MRI. But in which type of headache usually you will do? Okay, so there is a specific guideline in Mrcpch Red Book. That is if investigation imaging is important, if you suspect there is a pathology, sometimes we do MRI. Okay, what are the indication? If there is a red flag, like you cannot classify any headache, unclassified type, like migraine, tension type. These are the classified headache, but you cannot classify this headache. This is not migraine, this is not tension type. So then you will do CT scan. But migraine, CT scan, this is primary headache. In the migraine, tension type headache, cluster headache, these are called primary headache. In these cases, we never do CT scan. Okay. Next, first and worst headache. The child said, I felt like I am dying. This is worst headache of my life. We can do CT scan or MRI. Short history, but the headache is very progressing. Then we can do MRI. Then there is some neurological sign like focal sign, or there is some other sign, upper motor neuron sign. We can do MRI. If there is a balance problem, ataxia, then we can do MRI, because this may be cerebellar pathology. There is eye rolling, like, conjugation, deviation movement of the eye. There is seizure, okay, after headache. This is always pathological. Seizure and headache, they are not related with each other. Okay, there is one important headache that is called IIH, idiopathic intracranial hypertension. In that case, sometimes the child may develop seizure. Abnormal head position or head tilt are called torticollis. In this torticollis, the child may have problem with intracranial or extracranial pathology. In those cases, we may need sometime MRI or CT scan. Okay, so these are the particular indication for headache with MRI or CT scan. You normal headache, normal primary headache, you cannot do any CT scan or MRI. Now, the most common question in pharmacology, that is, what is the drug treatment? Drug of first line and second line. Adjuvant means you can add. Okay, drugs of first line and second line choice. So the most common drug previously was valproate. We used to use valproate for all child in generalized tonic-clonic. Now it is changed. Now, in carbamazepine is the most common drug. Carbamazepine we use for generalized tonic-clonic. This question came in exam, I think 2 years back, 2018. That what is the most common drug for generalized tonic-clonic seizure, and it is carbamazepine. You can use sodium valproate second as after carbamazepine, then lamotrigine, oxcarbazepine. You can also use clobazam, okay, and topiramate, but these are adjunctive. When the child is not resolving by primary drug, we can add on. There is add-on, step up therapy, step down therapy. You have to know what is step up procedure, what is step down procedure, right? What is add-on procedure. Now, tonic or atonic, we use sodium valproate. As a adjunct, we use lamotrigine. Now, absence seizure, first drug, ethosuximide, lamotrigine, sodium valproate. But here I will mention sodium valproate is the best drug for absence seizure for boys. But for girls, we will use ethosuximide. Lamotrigine is a little bit costly, okay? We can use ethosuximide. Now, myoclonic seizure, we will use levetiracetam. Here, one is remember that absence and myoclonic, these two seizure, carbamazepine is contraindicated. Why? Carbamazepine increase the seizure threshold in absence and myoclonic. Okay, so absence and myoclonic, we will not give carbamazepine. This is very important point. So ethosuximide, lamotrigine, sodium valproate are best for absence seizure, and levetiracetam, sodium valproate, topiramate are best for myoclonic, and we will never give carbamazepine in absence and myoclonic. Now, focal seizure, this question came many times. Carbamazepine. See, carbamazepine is the best drug for complex partial, benign partial, or simple partial, and generalized tonic-clonic. Carbamazepine is the best drug. Okay. Then lamotrigine, levetiracetam, oxcarbazepine, and sodium valproate you can use. Prolonged repeated seizure at home. What do you mean by community? Community means at home. Community. You will use Buccal Midazolam. Okay. Then rectal diazepam we now do not use, and lorazepam IV never, it will be used in home. It will use in ambulance or GP. A GP can give, or ambulance paramedic can give, but never ever mother will not give. Okay. Next, convulsive status epilepticus in hospital. This is the answer of some doctor was asking, but what is the definition of status? Status definition is 5-minute convulsion without regaining consciousness. This is called status. So you will wait for 5 minutes, because in hospital even it is not called status if it is 2 minutes or 3 minutes or 4 minutes. 5 minutes is called status. Okay. So this is lorazepam IV or diazepam IV or Buccal Midazolam you can use in hospital also if it is status. If it is refractory, you will use Midazolam IV or generalized anesthesia like propofol or thiopental sodium. Okay. Dr. Weeping is asking that sleep myoclonus, does it resolve by age, and any treatment of sleep myoclonus recur? Any pathology behind that? Very good question. I will answer this question, okay, after some time when we are going to slide. This slide is present, okay. Sleep myoclonus is called funny turn. We have a slide for funny turn, okay. Just wait. Now, next question. Until now, guys, any question about the drug treatment of epilepsy? Today, we are discussing a very common topic in Mrcpch exam, that is called epilepsy. We are discussing each and everything about epilepsy. Anything now? Question?
Madam, for generalized seizures, the drug
Yes,
of choice was mentioned carbamazepine.
yes.
Uh, but I have, like, recently I have read in NHS website, it is still given as valproate for generalized.
Okay. There are difference in trust to trust. Like you might read some Ghosh trust, like, Guys and Thomas or some other hospital like this. There are difference between trust to trust. But this is partner in pediatrics, this red book. Okay, we will follow the red book one. Okay. What is written
Okay.
in red, that is the best. We will follow that one. For our exam, especially for our exam. Okay. Now, next is, this is the very, very important chart, guys. This I took from Task Cases book. Very important chart. This you have to memorize by your heart. That is called Pharmacology, mechanism of action of anti-epileptic drug. This box, every year, every session, this box usually comes in exam. You will get 1 or 2 questions from this. Okay. So, uh, So most of the drug which we use for absence seizure are calcium channel blockers. You see, ethosuximide. You see, ethosuximide is a calcium channel blocker. Then you see that sodium valproate also has calcium channel blocker action. Then, then what we use? Lamotrigine. Lamotrigine also has some action on calcium channel blocker. So you remember that mostly calcium channel blockers drugs are used for absence seizure, and mostly generalized seizures are sodium gated channel blocker. Like let us see what are the sodium channel blockers. Who can tell us sodium channel blocker drugs mainly? What are the drugs for you we use for generalized tonic-clonic seizure?
Phenytoin, sodium
Phenytoin,
valproate.
sodium valproate, very good. Then carbamazepine, then
Mm.
lamotrigine also. Okay, topiramate we can use in generalized. So these are the drugs
Tropinamide.
used for generalized seizure. Okay, now I think it will be easy for you to remember that most of the calcium channel blockers drug are usually they are absence seizure drug, and most of the generalized tonic-clonic seizure drugs are usually sodium voltage gated sodium channel blockers. Okay, now another some drugs like topiramate. Topiramate has many action. You see, topiramate is now the first line leading drugs coming out. You see, topiramate action. How much action? Topiramate has sodium channel, calcium channel, GABA channel, glutamate channel. Every channel has action. This is topiramate. That's why I call topiramate is the boss. It's the boss of all drug, but it is very costly. Believe me, it is very, very costly. We don't use. It is very costly. So now next. Vigabatrin. The name is V-GABA. I mean, there is GABA, something GABA. What is GABA? GABA turnover. So Vigabatrin is a drug for GABA turnover.
Mm.
Vigabatrin. Okay. Now gabapentin. Again GABA. So there is also GABA turnover activity. Okay. Gabapentin. It has sodium calcium channel and sodium channel action. Okay. Now, ethosuximide is the calcium channel blocker. Benzodiazepine, it is GABA receptor agonist. GABA agonist, benzodiazepine. Also phenobarbital. These two drugs we use, remember, we use during status epilepticus. Like status epilepticus, what we use? We use phenobarbital in status, and we use benzodiazepine in status. So these two drugs we use in status epilepticus, they are GABA receptor. Okay. So is it clear now? Is it easy for you? I think like this I remember always. Okay. So this box is very, very important.
Yes.
Okay. Now next. This is very, very paid question, but very easy, right? Some people are laughing why this is today, but I'm telling you, most people in the exam hall, in the exam stress, they forget this pathway. From the lateral ventricle, they think cerebral aqueduct is coming, but no. From the lateral ventricle, there is interventricular foramen that is called foramen of Monro. It goes into the third ventricle. Okay. And third ventricle to fourth ventricle is cerebral aqueduct or aqueduct of Sylvius. From fourth ventricle, there are three foramina. There are two lateral foramina that is called Luschka and one medial foramina that is Magendie. This Luschka and Magendie, three foramina, goes into subarachnoid space of the brain to the spinal cord. So it is circulating in the central canal, and goes into the subarachnoid space, right? And then there is some venous sinuses in the brain. They absorb. So the lateral ventricle that has choroid plexus, these are the plexus like blood vessels, they secrete the CSF. And the reabsorption occur in arachnoid villi in the venous sinuses. Okay, this pathway many people forget during examination. And who can tell me that obstructive hydrocephalus, congenital obstructive hydrocephalus, what is the most common cause of congenital obstructive hydrocephalus? Most common?
Aqueduct of Sylvius narrowing.
Aqueduct of
Yes.
Sylvius.
Yeah, cerebral aqueduct narrowing. This is the most common cause of congenital hydrocephalus. Very good, very good. You guys are really very good, and I am very much hopeful that all who join today, they will pass. All of you are really very good. Okay, just you need a little bit sharpener, you know. Okay, so the funny turn. Okay, this is very common question in Mrcpch part 1, part 2, even in also. What is funny turn? These are the non-epileptic paroxysmal event. Okay, paroxysmal means sudden and severe event. These are called funny turn. They are not seizure. Okay, they are non-epileptic. These are called funny turn. Nowadays, the nomenclature changed. Previously, they are called non-epileptic seizure event or non-epileptic event. Now they are called funny turns. Okay. And these funny turns in the GP in the United States, when any parents comes to a GP usually call it funny turn. And then if it is not severe, they usually counsel and return the parents at home, but there is certain red flags when to return. Okay, so we will come to know what are the funny turns in pediatrics. These are the funny turns in pediatrics. Okay, can you see the screen? Can anyone read what are the funny turns? Can anyone read with us? What are the funny turns?
Reflex and
Reflex and
oxygen.
oxic seizures,
Yes. Then
syncope, breath
yes,
holding attacks,
yes,
benign neonatal sleep myoclonus,
yes,
night
yes.
terrors, gratification disorder.
That is yes. Can anyone tell me what is the difference between night terror and nightmare? Very common question in MRC.
Yes, ma'am.
Yes.
Ma'am, in night terror, the baby in the morning will not remember that what happened last night to him or her. And in nightmare, she will remember the event.
Yes, very good. This is the most important topic. And can you tell me which one is more dangerous, nightmare and night terror?
Night terror.
Terror is more dangerous.
Which
Night
is
terror.
Night terror, maybe, ma'am.
actually nightmare is logical. If the child is repeatedly nightmare up to certain age, like up to adolescent, it starts with 2-3 years. Okay, sometimes it stops with the adolescent. But when a child is adolescent means after 10 years, 11 years. When a child is adolescent, if the night terror persists, this is bad. You need to refer. Okay, but nightmare has an impact with the development. If child is seeing repeatedly nightmare, he will have very less sleep. At the night terror, usually the child become tired and then sleep after the event. Sometimes they're screaming, sometimes they're walking, running. Okay, so they become very flushed. There is a hyper pupillary mydriasis, flushing of the face. This is night terror. But night terror has less impact on the child's development. But nightmare is more impact, has more impact. The child cannot sleep usually a long time after the nightmare. In the afraid, they are very much afraid in nightmare because they remember the event. Okay. So this reflex anoxic seizure, syncope, breath holding, we discussed. Now this benign neonatal sleep myoclonus. Anyone can have any idea what is this sleep myoclonus? Neonatal. That means it started from the neonatal life, right? So how long does it persist? It persists usually up to 3 to 4 months. Very rarely it persists beyond 6 months. Okay, so it is a neonatal myoclonus, and usually it occurs during sleep. It can be partial, it can be bilateral, can be synchronized, can be asynchronized, can be mild variety of jerking, can be very severe jerking. Okay, this is benign neonatal, and the most important is it is benign. Usually this does not recur. Okay, there is no recurrence. Usually it resolves by 3 to 4 months. And when you touch the child, the seizure stops. This is benign neonatal sleep myoclonus. Okay, and usually there is no risk factor like asphyxia, hypocalcemia, hypoglycemia. There is usually no risk factor. No EEG is needed. Nothing. No investigation. In this type of here, these are the funny term like reflex anoxic, syncope, breath holding. They do not need any investigation. They do not need any treatment except if it is severe. Suppose syncope is severe, what we will do? Pacemaker, long QT, it can be long QT syndrome, we will do pacemaker, or we will do cardiac evaluation. Suppose breath holding attack, we will do iron deficiency anemia evaluation, we will treat with iron. Suppose it is night terror, but the child is adolescent, now not resolving, we will refer to the neurologist for some anti-epileptic drugs. Now, what is gratification disorder? It is actually infant masturbation. Okay, it is abnormal, involuntary. The child cannot resist. There is some tonic contraction movement of the genitalia. The child, it usually, the treatment is prevention. I mean, don't let the child, like, divert the child's mind. Even in the reflex anoxic or breath holding, you will divert the child mind. Okay, diversion. These are the only treatment for this gratification or something. Okay, guys, then any more question now until this? Okay, this is a very important slide. This is from the AKP cases book, the mechanism of action and the side effect of methylphenidate, that is the drug of choice for ADHD. We have to remember that ADHD, that is attention deficit hyperactive disorder, okay, we do not use drug until the child is preschool. The child is not going to school, we do not use drug. And if the child is very much aggressive or very much upset, very much hyperactive, then we do parental counseling. I mean, we give parental training for how to behave with the child. Then if the child is not like, still he is doing some hyperactivity, inattention, impulsivity, these are the three criteria, right? Hyperactivity, inattention, impulsivity. These three criteria, if it is persistent and the child is going to school, then we give cognitive behavioral therapy to the child, first of all. If then the child's symptom is not resolving, we refer the child to the mental health services, that is called CAMS, Child and Adolescent Mental Health Services. It is vital for all the cases of ADHD. Remember, this kind of questions will come and it seems very easy, but during exam stress, it is the difficult question. Okay, it becomes very difficult. So first of all, we comes to know that during ADHD, we use methylphenidate when if the child has significant school problem, like he is going to school, but he cannot concentrate on the school, the teachers cannot make him concentrate on the school. So this is, then we will start methylphenidate as a first line. But this methylphenidate is a very actually they have some side effects like growth failure. So first of all, we will monitor the child growth, height and weight, and we'll put it into the growth chart. Then every 6 monthly, we will do this growth. We will plot this in the chart. Is there is any growth failure, we have to stop the drug. There are some other cardiovascular side effects like tachycardia, arrhythmia, hypertension, sleep insomnia at night but not at day, insomnia at night. Okay, tics, constipation but not seizure. There is no seizure but there is tics and constipation. Okay, so these are the side effects. And what is the mechanism of action? It increases dopamine level in the brain. Okay, so this is actually we have to remember that it increases dopamine act on the frontal lobe and it suppress the seizure. Okay, so this is, there is another drug like atomoxetine, dexamphetamine. Okay, they're also used. Okay, sometime we use modified release preparation. Okay, so these are the drug treatment for ADHD. Okay, ADHD is one of the important topic which will be highlighted in child psychiatry. Also, as I am doing neurology, I just highlighted ADHD. Okay, guys, any more question now? Anyone? If you have, you can ask anything regarding the part one. Yeah, there is some chat question. I can see there are some question like, yes, anyone? Dr. Malisa is asking, bronchiolitis was seizing in the hospital. Not all bronchiolitis have IV, most NG if anything. So why observe? Not site for IV. Lorazepam at 5 minutes if still seizure. Yes, lorazepam IV if still seizure. Yeah. I did not get your question, Dr. Malisa. What is the relation of bronchiolitis with seizure? I did not get the question. Okay, difference between febrile myoclonic and febrile myoclonic and febrile seizure. Febrile seizure is not only myoclonic. Febrile seizure can be generalized tonic-clonic, can be focal, can be myoclonic. Febrile seizure means seizure with epilepsy, seizure with fever. But epilepsy is not fever with seizure. Epilepsy is afebrile. So don't mix up these two conditions. Myoclonus is a epilepsy and febrile seizure is febrile seizure. This is different. Febrile seizure can be generalized tonic-clonic, can be myoclonic, can be focal. But epilepsy is not with fever, without fever. Okay. Yeah, and another question is regarding sleep myoclonus. Okay, I gave you an answer about sleep myoclonus. Okay, guys, so I think if you don't have any question, we will just now stop our session. Dr. Malisa is asking, bronchiolitis, who had a fever with seizure 2 minutes? Normal glucose, says FiO2 normal. Why not IV instead of observing? No, with 2 minute seizure you cannot give IV because there is indication of specific indication for IV, that is 5 minute seizure. And if the child is hospital admitted for bronchiolitis, with 2 minute seizure, we don't take it as seizure disorder. We don't take it as status epilepticus. 2 minute seizure is not harmful for the brain. 5 minute seizure is harmful for the brain. That's why during 5 minutes, we will give IV lorazepam. Okay, we will wait. We will give left lateral position. We will calm the child. Okay. Any more question, guys? Okay, so give me the feedback, how you felt about this session. Anyone can open the mic. How you felt about this session? Was it helpful for you or
Yes, ma'am, your lectures are so helpful. Actually, I am preparing for AKP. I am
yeah,
just want to know, is there any booking for your lectures about that
yeah,
session?
I'm lecture booking for part one, dear, not for AKP. If you are a part
Mm,
one student, then I can help you. But if you are AKP, I have no classes for AKP. Actually, I am very busy for my exam also. So I'm also
okay, okay.
preparing. But many students contact me actually every day that, madam, please give us some class for AKP. But I'm still
Yes,
sorry.
if you
Okay.
can manage, because your lecture is very good. Today I
Thank
attend your
you.
lecture.
Thank you. Okay, any more comments? Anyone? Yeah, guys. So if you feel any more topic is difficult for you, just put me message on the Facebook group or WhatsApp groups. Okay, then we come to know that this topic, like this neurology, some people asked me to do this coverage. That's why I did today. Okay, so you can ask me in the groups. My Facebook is a Clinical Group of Excellence, Mrcpch Clinical Group of Excellence. You can ask me any question or anything. So I hope this session.
Excuse me, ma'am, will you briefly explain the difference between night terror and nightmares? Just briefly, ma'am.
Okay, okay. So night terror, actually the child cannot recall the event. The child is very much terrified, and it occurs during 90 minutes of sleep within 1.5 hours. Okay, usually within 60 to 90 minutes, the child become, wake up from sleep, started running, started crying, jumping. It's like he's seeing something and he's very much afraid of something. And then he's flushing, like he has, he's sweating, hyperventilation. And then parents come down, okay, like sleep, there's nothing, sleep. And then parents usually lose the cloth, usually come down the child sleeps, and there is no problem in the morning. but but nightmare is not like that. The child feels very much restless during sleep. The child is still sleepy, but he is feeling some, restlessness in the sleep, and he is not waking up, but he is like crying inside the sleep or something. And in the morning the child can recall full event. Okay, that's why this nightmare has an impact on the child, because he can remember the nightmare. You remember like that, there is a show, TV show, for nightmare. Name was Nightmare. Okay, Nightmare. A child who sleeps and he goes into some place. Okay, that is another world. So that was a nightmare. So nightmare, any child can remember, but night terror, he cannot remember. Okay.
Okay, ma'am. Thank you.
Okay. Any more question? Anyone? Okay, so guys, so I hope this was helpful for you. Now I will take leave from you, and if you have any more queries, any more comments, you can put this comment on the live. Okay. See you then. See you. Yes, inshallah. With next, I will do some statistics and I will do some ethics also. Yes. Thank you, everyone. Bye bye. Assalamu alaikum. Good night.
Thank you so
Thank
much,
you,
ma'am.
ma'am.
Thank you, ma'am.
Thank
Thanks a
you.
lot.
Thank you.